Okay, perfect. I'll just get started because I'm sure there might be a couple more people that join us as we go. But thank you everyone for joining us today. So today's webinar is going to be hosted by our ARC Northwest Coast. So I'll be kind of doing a bit of a Q&A about some of my research, and we're going to be focusing, we've also got Sander here today as well. Unfortunately, Megan Reedman couldn't make it today, and neither could Laura. So it'll be me and Sander kind of leading the session. And we're going to be focusing on enhancing dementia research through patient and public involvement and engagement. And we also have a special guest today, who is Jackie Cannon, who is CEO of the Lewy Body Society. And she's also been a public advisor who's been working with the Liverpool team for many years now. So Jackie is also going to be involved in this webinar and speak to us today as well. So I'll just give you a little bit of an overview of I'm sure everyone already kind of knows all about the importance of PPIE in dementia research. And it's critical as it brings perspective from those directly affected by patients, caregivers and the wider community into the research process by actively engaging individuals with lived experience. PPIE ensures that the research is more relevant, patient-centred and tailored to real-world needs. Again, not going to spend a huge amount of time on this, as I'm sure you all already know all about the importance of PPIE in dementia research. And one of the things that we wanted to focus on today in this webinar is we wanted to just focus on our specific experiences of integrating PPIE in our fellowship projects. We wanted to also discuss some of the challenges and strategies for meaningful engagement, and also some next steps for how we think that PPIE should be progressing in the future. So this is just a little bit of a rough outline for the session. So I'm going to hand over in a second to Jackie Cannon so she can give us a little bit of an introduction. And then we've decided to do the session more of a bit of a podcast style. So we won't really be using slides, but it'll be more of a first, Jackie's going to do a bit of a Q&A with myself, and then we've got a pre-recording from Megan, who's done a bit of a question answer as well, and then we're going to move over to Sander, and then we're also going to ask Jackie some questions about her experience as being a public advisor as well. And then we will also open it up if anyone has any questions for Jackie as well. So do bear that in mind when you're listening to Jackie talk about her experiences. If you've got any questions, you'll be able to have the opportunity to ask those at the end. And then we'll give you a little bit of a break, a little 5-minute break, and then we will then put you into breakout rooms for about 15 minutes to discuss your PPIE experiences and maybe some of the challenges you've had as well. And then we'll bring you all back to feedback at the end. So I'm just going to stop sharing my screen. And Jackie, did you want to do a bit of an introduction?
Yeah, good morning everybody. So I'm Jackie Cannon, I'm CEO of the Lewy Body Society, and as Megan said, I've been a public advisor for quite a few years now. I think we'll start off with questions about individual projects, and then we'll go on to specific questions for each of the researchers that we've got here today. So Megan and Sander, can you explain your research focus for your fellowship project and what you hope to achieve with it? Megan?
Yeah, so I'll go first for the questions, and then I think we're going to play Megan's recording. Okay. So in terms of the focus of my fellowship project is I'm looking at singing and dancing interventions and the impact that they have on people living with dementia and their carers as well. So one of the main focuses for my research is we wanted to have a specific link to making sure that we look at the impact of these interventions for both people living with dementia but also their carers as well, because a lot of previous research just kind of focus on the person living with dementia and not the impact that it has on their carers, and then how that interlinks with kind of delaying things like residential care and increased support that they need in their home. So that's kind of the main focus on my fellowship project. So for this project, I'm working with 2 local charities, one that is based in Liverpool called the Brain Charity, and they offer a Music Makes Us Sing and Music Makes Us Dance intervention. So I'm doing a bit of a service evaluation on that research with them. And then I am also working with another charity, which is based in Lancaster. They now have 6 groups actually, because I guess they're kind of based all over now, because they do have 6 groups based all across the UK. And they offer a singing intervention support service in the community, and they also offer like a sociable lunch. And in terms of what I'm hoping to achieve with this research is I'm hoping that we'll be able to kind of highlight some of the benefits of these intervention services for both people living with dementia and their carers. And one of the main things I'm hoping that we'll be able to achieve from it is to be able to kind of help these charities evidence the impact of their services that they're providing, which will then kind of help them to be able to get more funding and more support if they can kind of show some of the impact of their services that they're offering.
Could you give us an overview of the current stage of your project and the next steps over the coming months?
Yeah, so the current stage of my project at the minute is because I've kind of got 2 different service evaluations, they're at slightly different stages. So for one of them, I've completed the data collection for that now, and I'm in the process of writing up the project. So hopefully that will be ready and kind of starting to get ready for publication in the next few months. And then for the second part of it, for the lyrics and lunch part of it, I'm still doing some data collection for that. So I've been using mixed methods, so we've got most of the qualitative data now, but just trying to get the numbers up for the quantitative data. And then in terms of the extension that we've all been given, I've kind of been working on thinking about where to take it further. So my plan is to kind of hold a PPIE engagement event in around January or February time to kind of discuss with them, share with them the findings that I've got so far, and ask them kind of where they want to see it going next and what they think that we should be looking into.
Could you share a particular surprising or unexpected finding from your research?
Yeah, that's great. So one of the, I guess, particularly surprising or unexpected findings that I found from my research was so we wanted to look quite broadly in terms of the impact for people living with dementia and their carers, and we kind of expected that the interventions had quite a wide impact on those people. But we also interviewed a lot of the service providers and the volunteers that were working on these services and developing these services and delivering these services to the community. And one of the things that I kind of really didn't kind of expect to come through as clearly was kind of like the impact that it actually has on them as well, in terms of the impact it has on their well-being and in terms of getting involved with the community, and kind of just demonstrating that the impacts of these kind of community engagement and support services for people with dementia really do kind of have such a wide impact, even as far as kind of the volunteers that are engaging in them as well.
How has patient and public involvement changed the way that you approach your research?
So typically I've kind of come from a psychology background. So my PhD was kind of more experimental, more psychology based, and less applied than some of the research that I'm doing now. So I would say kind of typically a lot of previous research, or some of the previous research that I've done has been more kind of theory driven. However, kind of moving into this role and doing more applied research, and even when I was doing my PhD back then and I was doing kind of more experimental, more theory driven research, it was always the conversations that I had with people that were kind of in between the data collection that I did, and they were just kind of ad hoc conversations that really kind of like sparked the ideas for research and kind of identified those gaps in the research. And it was kind of like having those conversations with people during my PhD data collection was when I was kind of thinking like that's the really valuable bit in terms of like discovering where we need to be looking in terms of research and speaking to people about their experiences. So kind of going into more applied research and things like that, it's really having those experiences really kind of shown me that that is how all our research could be kind of driven, and by talking to people and kind of like really led from speaking to people first and asking what the need is and kind of developing the research there, rather than it being theory driven, which was kind of how I approached it previously. So yes, that's kind of how I've changed in terms of my approach from now on.
Can you share an example of how patient or public input has directly influenced your research directly or the outcomes?
Yeah, thank you. So I guess one of the examples would be with my current fellowship projects that I'm doing now. So when I was speaking to people about doing the service evaluation for both of the charities that I was working with, I kind of wanted to go into those discussions with a really quite a big open mind in terms of what outcomes we were going to assess and kind of how we were going to look at the impact. Because I didn't want to kind of go into that meeting with some preconceived ideas and think, oh, okay, well, this is the set of outcomes that we're going to look at, and these are the things that I'm guessing from previous research or assuming is the impact of these interventions. So I really sat down with them and kind of said, you know, you've been involved in these services before. What impacts did you see on yourself, and what impacts did you see on your carers, and vice versa? And really kind of worked with them to ask them exactly what outcome measures they wanted included, and what they felt was the most impactful outcome measures that were meaningful to them from these interventions, and then kind of went from there.
How do you see the role of PPIE evolving in dementia research over the next few years?
Okay, so I might answer this question in terms of how I hope that it'll evolve in the next few years, if that's okay. So in terms of how I'm hoping that it will evolve, is that I'm hoping that PPIE involvement in dementia research will become kind of much more embedded than it is now. I think we are able to do as good of a job we can do with the funding that we're given in terms of being able to, but I do think that public advisors should be kind of like being able to have opportunities to be more of core members of research teams. So at the minute, we are able to kind of pay them on like an ad hoc basis and fee basis as to that for their involvement and things like that. But we also have some permanent members who are public advisors in our research group now, and seeing the difference in kind of how those two approaches work and how those two roles are slightly different, where someone is funded for 12 whole months for a project and they're contracted to come in one day a week, they've got an office space, seeing that it work like that, they are much more able to become an integrated member of the team, and it kind of means that they are really fully getting compensated for all of the work that they do. And I hope that that's how eventually it will go with, in terms of getting permanent kind of contracts for public advisors, where they can really properly embed themselves in the research team in a more integrated way.
Thank you, thank you, Megan. Absolutely agree with your last comments. Are we going to show now Megan Rose's recording?
Yeah, thank you, Jackie. Sean, you might need to click the permission to share the audio. Sorry,
2 seconds.
it's okay. Sorry, I should have introduced Sean earlier, and I'm sorry I got carried away and I didn't. But Sean is our communications officer at the University of Liverpool, and she's been helping us with the webinar. So thank you so much for doing everything you have.
It's okay. Sorry, it's not letting me share the permission. I'll stop sharing and try again. Sorry, I knew this has happened. I have practiced everyone in case you thought I hadn't. Could you just let me know if this is okay when this comes on?
With
Meg.
Perfect, that's fine.
Sorry, everyone.
From my end for you to all listen to as part of the webinar. I'll hand over to Meg.
So I'm going to ask you some questions about your research and about your PPIE involvement in your projects. So can you explain your research focus of your fellowship and what you hope to achieve with it, please?
Yeah, sure. So in my fellowship, what I am looking at is hearing loss as a risk factor, specifically for Lewy pathology dementias. So that's both Parkinson's disease dementia and dementia with Lewy bodies. So we're kind of approaching this topic from two or three different standpoints. The first being we're conducting a big data analysis looking at whether having a hearing impairment significantly increases the likelihood that somebody goes on to develop incident Parkinson's disease dementia. So that's a UK Biobank large data analysis, specifically focusing in on Parkinson's disease dementia. And the reason for that being that there is presently no diagnostic code for Lewy body dementia in the UK Biobank. Once we've kind of done that big data analysis, we're going to look at the experience of hearing loss in Lewy body dementias from a more qualitative lived experience angle. So at this time, we're going to be speaking to individuals who live with a Lewy body dementia and concurrent hearing loss and asking them about their experience. So tapping into understanding how having hearing loss may be impacting the individual living with Lewy body dementia, how they find the audiology services, do they think the services are appropriate, do they struggle with any of the tests and stuff like that. Critically, at that time, we're going to speak to both people living with Lewy body dementia and their caregivers, so unpaid carers, to get both sort of experiences there. And then there is a third phase that we're going on to look in more detail, gathering some experimental evidence as to how hearing loss may be impacting the individual living with Lewy body dementia in terms of their symptom presentation. So is it making the fall likelihood, increase in fall likelihood, or is it impacting cognitive decline in any way? So gathering primary evidence there. Sorry, that was a right ramble.
No, that's great. Thank you so much. And could you give an overview of the current stage of your research project and the next steps over the coming months?
Yeah, for sure. So I just realised I spoke about everything previously in the "we are going to" tense when I've actually already done it. So the UK Biobank big data analysis is complete, as are the interviews. They are too complete. So now I'm going on to the third phase of the study to collect the experimental data. So I'm currently in the process of training up to conduct all the audiology assessments and get NHS ethical approval to conduct this data analysis. So yeah, and once we've collected that data, what we plan to do is bring all three sort of studies together and zoom out sort of and look at all the evidence together and see what it kind of suggests in terms of implications for clinical care of people living with Lewy body dementia. And one thing that we are in the process of thinking about doing and have funding to do is working with Jackie, who I'm sure you'll speak to in a bit more detail later, to co-produce some information booklets about hearing loss in dementias, but specifically Lewy body dementia, to distribute to people who use the Lewy Body Society services, and also hopefully get in different clinical settings. So these leaflets will be disseminating evidence, but also providing practical guidance on what to do if you are living with a dementia and also have a hearing impairment. So where to go, what you need to do, because what we have been seeing is one of the biggest barriers is that people who have a hearing impairment might never go and get it checked because they don't really know where to go. They don't really know what to do. Obviously, that is a barrier that we see time and time again. So we're trying to address that barrier. The first step being sort of information booklets. So yeah, I guess that's kind of what I did.
That's great. It sounds like you've done a huge amount of work so far and lots more to come. And could you share a particularly surprising or unexpected finding from your research?
Yeah, so obviously I've got to caveat this by saying that the finding that I find particularly surprising should be treated with an immense degree of caution due to the sample size of people with incident Parkinson's disease dementia. So within the UK Biobank, only 101 participants were obtained a diagnosis of dementia in Parkinson's in the time frame that we analysed. So it is a small sample. So we're very much treating it as pilot data. Don't want to go out there, put my head on the chopping block. I just want there to be some skepticism over. But essentially what we observed in this UK Biobank analysis is that a hearing impairment does not significantly increase the likelihood of incident Parkinson's disease dementia, which is really quite interesting. Obviously, with a very cautious hat on, that may suggest that the relationship between hearing loss and dementia is in some way potentially subtype specific. So that could potentially suggest that these higher level initiatives that we're applying to hearing loss and dementia might not be appropriate for every different type of dementia. And what we really need to be doing is thinking about the rarer dementia subtypes on their own independently, which is something that I know Jackie and her team are really keen on. Lewy body dementia is so incredibly different from Alzheimer's disease dementia. So we shouldn't always put it in the same box. It needs to be treated independently. We need to think about it independently and provide support that is tailored to the specific needs. And that analysis supports that position. But like I said, let's be skeptical because of the sample size.
That's great, thank you. And now we're going to move on to some specific PPIE questions for you. So how do you involve patients and the public in your research process? And could you walk us through a typical PPIE approach in your project?
Yeah, so my project came into fruition so if I go far enough back, this idea, the whole concept of looking at hearing loss in the context of Parkinson's disease and Lewy pathology dementias came about from an off-the-cuff conversation that I had with an individual who lives with Parkinson's that I, had during my PhD. So this individual kind of was discussing evidence they'd seen about dementia with me, and said, I have hearing loss. My brother, who also has Parkinson's, also has hearing loss. And when I go to my support cafe, turn around, everyone has a hearing aid in, sort of thing. So that's where the cogs started turning at that point. So we started thinking about, let's look at the mechanisms behind the relationship between hearing loss and dementia and think about it in the context of Parkinson's disease and dementia within Parkinson's. So in terms of public involvement and engagement, my project really initiated from a member of the public. It was very much initiated from somebody who lives with the clinical condition of interest. So it's been embedded right from the very, very start. That individual is still working on this project with me today. And as the project progressed, we've started working with Jackie. As the CEO of the Lewy Body Society and a former caregiver herself, Jackie has been able to reflect on her experiences and how this is an important issue that she has experienced throughout her caregiving journey, but also as a charity third sector provider. So both of those individuals were involved in developing the interview schedules. They've been involved in discussions around what we should be thinking about when we're doing the data collection that is forthcoming. But perhaps most importantly, they're authors on everything. And as I've said, we're working very closely with Jackie and her team to co-produce the information booklets. So it's literally every stage that you can have in the research process. Jackie and Ian are fed into it and giving their real lived experience, because otherwise, what's the point if nobody really cares?
That's great, thank you. And what strategies have you found to be effective in ensuring meaningful engagement rather than just token involvement?
Yeah, I think one of the biggest things for me is and I'm not sure what Jackie feels, but I feel like I personally have quite a good connection with the public advisors that I've worked with, in that I'm interested in them as people. So not just, you know, oh, I want to know how this experience has affected you. I'm going to pick your brains, take everything. More being like, I'm interested in you as a person. Let's, you know, have a chat about your, you know, like we often have random conversations about general stuff that has absolutely nothing to do with research. And I think that has helped the relationship foster, because it's genuine. It's not me just, you know, sucking all this information out of them. But equally with Ian, for example, I've helped him in a lot of different things. There were several times when he was struggling to get access to a service for his brother, so asked me for some advice and some help, and it's been like a real give and take sort of situation. So, you know, like fostering like a natural organic friendship, really, rather than seeing it as it's a different level, if that kind of makes sense. I think that's one of the things that actually makes it an opportunity that has the ability to go over time, a long thing, I guess. I don't know.
Yeah, no, that's great. It's lovely to hear about how you've been able to develop those relationships to be far beyond kind of just the research, and you've actually developed proper personal relationships with your public advisors. It also means that they'll feel more able to approach you if they have ideas for projects and stuff. So yeah, it's great.
Exactly. And we're asking them, you know, when you're talking to these people, you're asking them about potentially some of the hardest things that they've ever had to face, and some of the darkest days, and some of, you know, the most challenging experiences of their life. You can't expect somebody to feel comfortable to share those experiences with you if you're not, you know, like actively working on, you know, being an approachable, friendly, warm person, and you know, not just sucking information, I guess.
Yeah, no, absolutely. And how do you plan to continue or expand your PPIE efforts in future projects?
Yeah, this is something that I've thought about quite a lot. I'm incredibly grateful for the people that I work with. However, one thing that I think, given that my research focuses on hearing loss, the elephant in the room is that I've never engaged with somebody who is a British Sign Language user, or somebody whose primary form of communication is through sign language. And I would really like to engage in a public advisor role with somebody who is using sign language, because it's very very rich for me to say all this stuff about hearing loss, but not actually making any of the resources that I produce accessible to people who are profoundly deaf and use sign language as their form of communication. So I would really like to start like tapping into those sort of areas and working with charities there to support that. Haven't done it yet, I must admit. I do have some connections to how to go there, but I think it's just making sure that the public advisors that you work with evolve with the project. So as we start to go more into disseminating information, I need to be working with people who can make sure the information that I disseminate is accessible, especially when I'm talking about living with hearing loss. So I think that's the next sort of way that I would like to develop it.
That's great. Thank you, Megan. So that's all of the questions that we've got for you today, but thank you so much for pre-recording this for the webinar.
That's all right. And I hope you're all having a very good day. And just to let you all know, I am at a conference, an audiology conference, so I'm not just Skyping off.
Yeah, that's great. Thank you so much. I think Sandra's up next, I think.
Thank you. Sandra, I've got some questions for you about your research now. Okay,
yes,
so
Let's go for it, Jack.
Can you explain your research focus for your fellowship project and what you hope to achieve with it?
Absolutely, Jackie. Just to say that it's always exciting to hear. I've had Megan and the two Megans projects several times, but it's always exciting hearing it again and their passions behind it. So yes, back to your question now, Jackie. So my fellowship project is centered around the intersection of cultural and religious factors in dementia prevention, and the aim here is to address the needs of this underserved community. So my work sort of spans across several areas, each of them addressing particular gaps in dementia prevention among Black Muslim communities. So I have what I will call 3 mini projects within my fellowship project. So one of them is looking at the broader issue of what we call modifiable risk factors for dementia across various populations. So kind of like building on the findings of global research that has sort of examined risk factors such as education, social isolation, cardiovascular health, and how these contribute to the risk of developing dementia. Kind of like looking at how these risk factors are distributed among religious communities. So by investigating how these factors intersect with religious, affiliation, my research is seeking to create kind of tailored public health interventions to help prevent those risk factors, specifically among religious, communities, because I believe that these risk factors will be different when you start looking at subgroups of the population. And some research has actually shown that that is the case when you start looking at different, ethnic groups, for example, but no research has actually looked at religious communities, as a whole. Now, this sort of, brings me to the point where usually I like to talk about why it's important. It's important that I'm focusing on religious communities. I mean, this is because, religion as a social construct brings people together in unique ways that other constructs such as ethnicity do not, especially when we're looking at lifestyle factors, for example. So if you look at me, I'm a Black Muslim, and if you want to explore my lifestyle factors, it's actually quite very similar to another, let's say, an Asian Muslim rather than another Black African Christian. And this is why I'm interested in the concepts of religion. Now, the second aspect of my fellowship is trying to understand the way Black Muslims in particular perceive dementia risk or understand, dementia prevention. So this is looking at how, religious, cultural, and social factors sort of influence, the beliefs of Black Muslims about dementia and their risk, and also how to sort of prevent it. The aim here is that based on such understanding, we will be able to develop, culturally appropriate interventions to raise awareness among the Black Muslim community around dementia prevention. Now, the third aspect of, my fellowship, focus on exploring the relationship between religious practices and cognitive frailty. Now, this is not necessarily dementia. So cognitive frailty is the concurrent manifestation of being physically frail and having cognitive impairment, not having dementia. However, cognitive frailty is a significant risk factor for dementia. So people who are usually cognitively frail are 4 times more likely to develop dementia than those who are not. So if we can prevent cognitive dementia, then cognitive frailty, then we can reduce the risk of developing dementia as well. Another opportunity here in focusing on cognitive frailty is that cognitive frailty is reversible. So if someone has cognitive frailty and the right interventions, are being, implemented, it can reverse the condition, which means it can sort of reverse your risk of developing dementia as well. But again, coming from the focus of religious communities, I want to see whether particular religious practices actually reduce one's risk of developing cognitive frailty. And if that is the case, how can we sort of tap into that to develop interventions that will still be appropriate even for non-religious communities as well. So that is the third aspect of my project. So in sum, Jackie, my fellowship, is trying to reduce the disparities, or if you like, the inequalities in dementia prevention by sort of developing culturally competent, modules specifically for religious communities.
Thank you for that and such great detail. Could you give an overview of the current stage of your research project and the next steps over the coming months?
Absolutely, yes. Happy to do so, Jackie. So at the moment, my research is advancing through several key stages, each sort of progressing towards the goal of creating, culturally competent dementia prevention modules and trying to understand dementia risk within religious communities. So I'm going to talk about, those mini projects within my fellowship and how, where I am at with those. So with the project that is focused on, understanding the modifiable risk factors among religious populations, I am analyzing the English longitudinal study of aging data sets where I'm calculating what we call the population attributable fraction of 14 modifiable risk factors for dementia. Now, to sort of break that down, so what I'm trying to do here is I'm trying to understand if we get rid of a particular risk factor, by how much do we reduce people's, risk of developing dementia? Now, this has already been done among the global population. And a more recent, finding about this was published, in July, later in July. But I want to now understand this specifically among religious communities. So I have finished analyzing that data now. So over the next few weeks, I'll be finalizing a manuscript, with regards to that, hoping to submit it, for publication. I probably will shut up because I'm being tempted to say some of the findings that I've got, but I will hold on until it gets to the publication stage. For the second aspect of my fellowship, where I'm looking at trying to understand the views of Black Muslims around dementia prevention, I'm in the process of collecting data. So this is a qualitative study where I am using a narrative inquiry approach. So I'm in the middle of the data collection now. So I'm conducting one-to-one interviews, and I've already conducted some interviews already, almost gotten my sample size and the saturation that I am looking for within that data. So in the next few months, I'm hoping to start the analysis of that qualitative, data and, write out, my findings. For the third aspect of my fellowship, which is focused on the relationship between religious practices and risk of cognitive frailty, I analyzed the English longitudinal study of data sets also to explore that. The reason why I'm focusing on this data set is because it is the one that has sort of captured religious practices among the English population, but has also, collected data on, cognitive frailty. I have completed the analysis of that data set, and I have found some protective effects of some religious practices on the risk of developing cognitive frailty after controlling for all, various confounding factors. This protective effect is more pronounced among older adults, so people age 65 years and above. It's also more pronounced among females and those who actually self-identify to be affiliated to a particular religion. Now that's all been written up, and I have submitted a manuscript to the Journal of Social Gerontology. So, it's under review at the moment.
Thank you very much, Sander. Could you share a particular surprising or unexpected finding from your research?
Yes, absolutely. Research is always full of surprises, and I did have some surprises in my fellowship as well. So I think the first biggest surprise for me was, ideally, I had come up with this brilliant idea. I don't know where I got it from, Jackie. Man, I've been just sleeping and waking up and just having a brilliant idea to explore dementia prevention among Black Muslims. And I thought there was data lying down waiting for me to churn that data and come up with some exciting findings. So, I saw that the ELSA data set collects information on religious practices and also dementia risk. only to dive into this data set after making so much noise about my brilliant idea to find out that, for example, the Muslim population within the ELSA data set, it's only about less than 100 people. And the data, on Black ethnicity in the ELSA data set is less than 200 out of, a data set of over 10,000 participants. So that was one of the biggest surprise. That didn't kill the idea entirely. This then made me focus more broadly on religious communities rather than a particular religion per se. But that in itself highlights a gap in this area, which I am hoping to explore, in future. Another more recent surprise was that for the second aspect of my project, where I was looking at the distribution of risk factors among religious communities, I was sort of extending previous research that has been done and looking at 12 modifiable risk factors. This was published in 2020, by Lancet Commission. And I had gone with these 12 risk factors, seeing how they are distributed among religious communities. And while I was just about to start writing my manuscript, a new publication came out. It was now 14 risk factors, which actually meant that I had to update my analysis to these 14 risk factors. So that's a surprise in terms of the way, we are getting new insights into this area. But that's also a good learning curve to see that these are going to change as we gather more evidence on the risk factors of dementia.
Wonderful, thank you. Now we've got some specific PPIE questions for you. At what stages of your research do you engage with patients and the public, and why at those specific points?
Right. Okay. So, Jackie, I'd like to approach this question from two perspectives. I'll give you the textbook answer and I'll give you the reality. Okay. So, ideally, I'd wanted to engage, the public right from the very start of my research in terms of shaping the research questions and the ideas, through to collecting data, validating the data and then disseminating it. That didn't really happen like that for each project. It did happen for various projects, but it all didn't happen for one particular project. And I'll sort of talk about that in more detail when I'm talking about the challenges. So for the project looking at the modifiable risk factors, I'd wanted to involve the public right from designing the research ideas. I did talk to some members of the public, some people from the Black Muslim community about this research idea, but I didn't formally engage them in that process to sort of shape them. But I did get some insight from them, in sort of, in informal discussions. But I have completed the analysis now, but I've not ruled it off and involving the public. One of the things that I'm looking forward to doing is how to disseminate these findings for them to be impactful. Now, this is the stage that I am now, actively involving, the public as to what is the best way of disseminating these findings to, religious communities. For the project looking at, trying to understand the perspectives of Black Muslims on the causes of dementia, I was able to involve the public in the data collection stage. Now, again, the plan was to involve them right from the start, but there were challenges in getting the public advisors on board, and I'll talk about that, why it's quite unique for this particular project in involving, the public. But it's been great that I have got some public advisors involved in the data collection stages. We've looked at the interview schedule. They've advised on how to frame some of the questions. They've advised on how to go around some of the sensitive conversations, around dementia when talking to, the Black Muslim, community as well. I'm looking forward to involving them in the data analysis stage as well, the interpretation of the data and how to actually disseminate the results for them to be more impactful.
Thank you. You've touched on this a little bit, but what are some of the challenges you face when involving patients and the public in your research?
Right, so because my research was focused on Black Muslims, And at the Northwest Coast, the fantastic public, advisors, there's a pool of public health advisors. But I wanted specifically a black, a public advisor who was a black Muslim, and that was quite difficult. So there was one public advisor that I found and I got on board, but I needed another person. So that means I had to actually try to recruit a new public advisor. Thankfully, I've been successful in recruiting a second public advisor who is, a black Muslim. But that was a huge challenge, and this is why I couldn't involve them right from the beginning of the research project in terms of shaping the ideas. But I have gotten them on board, and I am sort of involved in them at the stage that I am in. And I like this beautiful diagram for the Northwest Coast Public Advisor team, which looks like a ladder with various steps as to the degrees and extent to which you can involve public advisors. I think I'm probably at the bottom of the ladder in terms of the way I'm involving public advisors. But one of the challenges has been, that the recruitment specifically for that, for this particular research project.
Thank you. And finally, how do you address issues related to diversity and representation in your PPIE efforts?
Absolutely, Jackie. Although I've been mentioning the Black Muslim population, but there's a lot of diversity within this population. So, in fact, the issue of gender, for example, is a very significant factor in terms of perspectives, on this particular topic. And the issue of some sort of social structure as well. So I'm trying to involve, people who are kind of at the leadership position within the Muslim community, and those who are not as well. And that's been quite difficult because, as you can see, Jackie, just looking for two public advisors to start off with generally was quite difficult, and trying to now break this up to these specific, public advisors in these specific roles has been, incredibly challenging. But I would say the fact that it's difficult does not mean it doesn't have to be done. So my hope is that in the future, I can, sort of identify, more members of the public in these different roles to be more actively involved, in my research project.
Thank you.
I think this is where we swap roles, isn't it, Jackie?
Yes, it is.
And if we were, having this conversation on the sofa, which would have been ideal, because that's the sort of style we're looking for. This is where we'll swap seats. But anyway, we have swapped it virtually. So now, Jackie, I do have some questions, for you now as a public advisor. So, Jackie, can you kindly explain to us how you became a public advisor?
So I became a public advisor a few years ago now, and that began with working with Dr. Clarissa Giebel at Liverpool University in my role as CEO of the Lewy Body Society. But I felt as I had something additional to give to the research community, in addition to being a CEO of a micro charity, because I got that personal lived experience. And after conversations with Clarissa, she said, why don't you think about being a public advisor? And I really didn't know what that meant. But now I think it's such a brilliant thing to do, for a lot of reasons that we will go on to in subsequent questions. But yeah, that's how I became a public advisor. Right.
Now, sort of following that from, your point about it's a brilliant thing to do, I believe that means it's been beneficial. Can you sort of expand on that, what are some of the benefits you have gotten from being a public advisor?
Yeah, because obviously my specific interest is around dementia, but I'm also working on other projects as a public advisor, like healthy environments, for example, trauma-informed approaches, and specifically in schools. So across quite a few different projects, and that has been really kind of opened up a totally different sphere of research, and things that I've learned about how to code interviews. I come from an analysis background, but that's in IT. So totally different analysis approach in looking at how to code interviews and looking at subjects that come out of those interview researchers. So yeah, it's been really good, and because I've not focused specifically on dementia as well, I think that has helped me.
Absolutely. But I hope, Jackie, I don't suppose this has been a smooth ride. There have probably been some barriers. Are there, are there any barriers that you would like to, sort of touch on, in terms of your role of being a public advisor?
Yeah, I think in Northwest Coast, I really genuinely don't feel that I've come across any barriers. I think the only barriers that I have come across is me working full time and not being able to give more time to this. And that's a self-imposed barrier, if you like. But I wish I could do more. But I don't feel that I've come across any barriers at all with researchers. As Megan Rose just said, people become friends. People develop relationships, and I think that is, and with other public advisors as well, not just with the researchers. So I think that, that is so important, and it just opens you up to different views, more different conversations, thinking about things, and if I think about like the Lewy body, and it gives me an opportunity to raise things in discussions like with Megan, have you thought about this? Just drawing on that personal experience, but being able, I think the benefit of being a public advisor is just being able to share your experiences. I'm on another project which is talking about dealing with comorbidities, and how you navigate the health service and the appointments, which touches on dementia but also touches on other things, because as we always say, dementia rarely travels alone, and a lot of people have other underlying medical problems, whether it's hearing, sight. A lot of people with Lewy body have heart conditions. You look at a scan of somebody with Lewy body and a scan of a heart of somebody that doesn't have, and you can see distinct differences in those heart scans. So it's so looking at comorbidities project, again, that was related but different. So I just think it's given me a lot of opportunities.
Right. I mean, that's very exciting to hear, Jackie, that you have an incredibly fulfilling journey as a public, advisor. Are there then any sort of top tips that you'd like to share for people considering involving, a public advisor in their future work?
I would just say, you talked about your particular project, Sandra, and trying to find public advisors that fit the criteria that you need. But and a lot of projects might experience that, but the sooner that you can engage with a public advisor at the beginning to shape the project, to understand those personal experiences of a public advisor, the better, because as the mantra says, research, you're nothing without us. So you've got to understand why the research is happening, why the research is needed, and not to make assumptions, because this is why so many people, whether it's dementia or other illnesses, for example, get misdiagnosed, because the medical professionals and the researchers don't have that public involvement, don't listen to a relative if they're describing symptoms. It's so important to have that public involvement voice.
Great, great. Very valuable advice. Thank you so much, Jackie. I think these are all the questions I have for you for now.
Thank you.
I'll now hand over to Megan.
I guess we're next just going to open it up to see if anyone else has any questions for Jackie. So if anyone wants to jump in and ask Jackie a question, feel free. Sarah, did you want to ask Jackie a question?
Yeah, hi there, Jackie. It's lovely to see you.
It's nice to see you as well.
Been a really interesting presentation. I actually wanted to ask, and I guess this is something harping back to because we used to work together a little bit, and I met you through Dementia United, which worked through the health and social care. What's been the difference for you between working with researchers from universities and working with an organisation like Dementia United, which is more policy focused? How have you found that to be different? Because it's both PPI, but just in different guises.
Yeah, very good question. Very good question, Sarah. I think, as you've just said, Dementia United, who I still continue to work with on young onset, and specifically on young onset and rarer forms of dementia. And I think the main difference is that, as you've just said, it's about policy. And I think with the universities, it's more about delivering interventions and actually providing deliverables, I think is the main thing. And I think you have, I think you, dare I say, a bigger voice. I think you have a bigger voice, and you can see where things are going. Hope that answers your question, Sarah.
No, lovely answer. Thank you, Jackie.
That's great. Thanks, Sarah. And thank you, Jackie. Does anyone else have any other questions? Oh, Paul, did you want to ask a question?
Yeah, I mean, just in the I guess the top tips that anybody would have. I mean, a number one top tip or something like that that could be shared with a wider group. That would be absolutely great.
A top tip as a public advisor.
Yeah, I mean, just I was talking more for everybody that's presented, really. You know, if they've got one top tip that they could give the rest of the group, that would be great. I don't know if you could do that later. I wasn't sure of the agenda, so I'm apologies if I've come in and asked a question at the wrong time there.
No, that's great. Did you want to go first, Jackie, or did you want me to go first? Or
you go first, Megan.
Yeah. So I guess my number one top tip would be like develop meaningful relationships, like beyond the research. That would be kind of my like top tip.
I guess for me, my top tip would be never give up on trying to involve the public at any stage of your research, even if you fail to do so right from the very start. Because the benefits, there are benefits at every stage that you involve them.
I think my top tip is, as Megan's just said, develop those relationships with the researchers, but use the lived experience that you have. Don't let it go to waste. You've gone through this journey, and if you can help another person or another family, then use that experience.
That's great. Thank you, Jackie, and thanks, Amber. Thanks, Paul, for a good question. So I guess we'll have a quick 5-minute break, and then at 5 past we'll pop everyone into breakout rooms, and I'll just kind of run through what we're going to ask you to chat about in the breakout rooms as well. But we'll let you all have a quick 5-minute break from your screens, but we'll come back at 5 past and get going again. Okay, so we'll get started again. Hopefully everyone's back. So I've just put up the slide just about the breakout room. So we kind of want to shift it so that now we can hear kind of some of your experiences of using PPIE in your research. So for the breakout rooms, we'd like you to talk about and explore some of the strategies that you've used to build and maintain long-term relationships with patient and public involvement in your dementia research. If you can discuss about some of the key elements of sustainable PPIE models that you've identified within your work, and how do you ensure ongoing engagement over the life of a research project. And then hopefully at the end you can share some of these maybe some successful long-term PPIE partnerships that you've been involved with either in this fellowship or previously. And if you get through that really quickly and there's more time, you could also reflect on some of the challenges that you've encountered when incorporating PPIE into your dementia research, and what specific barriers you have faced in achieving effective involvement, how you've addressed them, and if you can provide examples of kind of any innovative solutions or approaches that you've used to overcome these challenges. So I will pop this in the chat, which hopefully you'll be able to still see when you go into breakout rooms, just so you've got it there. I think Sean is going to do the breakout rooms because I don't know how to do them.
Everyone should be going to the rooms now. Yeah.
Yeah, so we've got a little notification up. Thank you.
Yeah.
Hi everyone, I think we've all kind of slowly filtered back in. So I can't pick on people, but does anyone want to volunteer kind of like what their group was talking about? I just feel like everyone's heard enough from me already. Paul, do you want to go first?
Yeah, so I was actually put in a breakout room with the colleague that I work with, Sue, but we met with Jackie and we talked about sort of the issues that have been discussed here in this session. And one of the things, the innovative things that Jackie's involved with, and we're involved with as well through our colleague Chris Poyner, is to, rather than have a project-specific PPIE group that is there for a project and then when the project ends, everybody just disappears, is to have some form of sort of structure. And Chris has set up a wonderful group in the Arc West Midlands that's now involved in multiple projects and sort of is a kind of a more of a permanent feature, and in that way you can have that investment with the people that are involved. And Jackie mentioned that she's doing very much the same up in the north there, so that's what we thought would be great. It's that sort of thing about doing a project, getting them involved at the beginning and then a dissemination event at the end, but then nothing else, and having a sort of ongoing engagement creates a better environment for all, I think. So that's what we talked about.
Yeah, absolutely. I think that's a really good point in terms of kind of like not just having people involved in one specific project and then losing contact and kind of having different people. It's kind of creating an environment where there's continued engagement for kind of years and that people feel supported and not just valued for that specific project, but just valued in across all research, different things and stuff. Giulietta, did you want to?
Yeah, I just want to say that we also discussed the fact that it can be a challenging situation if the same people are always in the group feeding to different projects, and if it's very important to have those long-term relationships. We discussed that in our group, but at the same time you need to be mindful to try to bring more people. I don't want to use the word renovate, but you do need to hear some other people's voices and what they think, because if not, it feels like very narrow. I don't know what you feel about it.
Yeah, no, I think that's a really good point. Yeah, definitely. Chris? you're in my group, so I'll let you summarise ours.
Thanks. Yeah, I think what Juliet says has some pertinence. And what we were talking about was the difficulty of engaging with people who are marginalised with dementia and avoiding tokenism, while also trying to balance like the pragmatism of getting a funding bid done. Because, you know, from a researcher perspective, there might be a tendency to think, well, you know, I've engaged with people with dementia, therefore I've engaged with people who are relevant to the cohort I want to speak to in my research, when actually that might not be the case. So in Pippa's case, she speaks to people at end of life and she goes and cares for people at end of life. And Pippa was discussing the challenges that she's had with her own kind of principle base by engaging people living with dementia who've not gone through that experience yet. So what, Pippa, do you want to talk about what you're doing as a result of that?
So I've realised that research questions and clinical developments are being developed without the input of people with severe frailty and or dementia, and that this group of people who are housebound by definition can't access focus groups. They don't get involved with surveys, and they won't be doing things online, but they still have really important stories to tell. So I'm using, because I'm a clinician, I'm using a QI methodology to access these people, to overtly, for my trust, address clinical questions of, you know, how well are we serving them with the changes towards hospital at home and virtual wards that's happening, but with the sort of covert ability as well to ask them what we should be looking at and what they'd like to be seen differently, to help work into a research question. And my idea is to go back to these people on, you know, maybe over a six to 9 months period, and actually see how their story changes and how their input changes, and if I'm working up a proposal to take it back to them. So I'm using a QI methodology to access people that have never been accessed before, to ask them what their experiences, what their wants are around research and clinical care. And I don't need ethics for that.
Yeah, that's great. Thank you, Pippa. It was really interesting to hear kind of about what it is you're doing and how you've gone about those difficulties. Sarah, did you want to summarise what your group chatted about?
Yeah, just quickly. So we had two really interesting points. I was with Sue and Catherine, and I think the first one was about, if you're working with both people living with dementia and care partners, how their experiences are slightly different, and who maybe gives you more of the narrative when you're working with both individuals. So I think in a PPI context, it's interesting to work out whose narrative you're gaining, and sometimes that's very complicated, especially if the person living with dementia is less fluent or less able to discuss their experiences. So I think that can be a barrier sometimes. But we also talked about more basic science and more biological and data related work, and how it can be hard to know when to bring members of the public into that and how to do that successfully. We did talk about whether that can be done around dissemination, but again, sometimes that's complicated and might seem a bit tokenistic, that, you know, at this point we're just telling you about it rather than, you know, actually asking you about it. And I didn't get a chance to mention this, but I thought it's useful for the group as well. I attended a meeting around PPI several months ago, where a point was raised, and I think it links in with what Megan Rose was saying about how important it is to form these quite personal relationships with people, but also how complicated that can become if you work with a lot of people simultaneously, and how that can actually put a lot of pressure in some ways on some researchers to maintain all these friendships and manage that. So I just thought that was an interesting point to raise as well.
Yeah, definitely. It sounds like you had some really good discussions, so thanks for sharing back. Is there one more group that that someone's not spoken from? I don't know. I think maybe one more. If not, I'll quickly just share one more slide before I wrap up. It's just a shameless plug about the Liverpool forum. So actually, I'm not going to get the slide in time, so I'll just kind of say. But yeah, there's the sixth annual Liverpool Dementia an Ageing Research Conference, which we are holding in Liverpool on the 23rd of October this year. So if anyone is interested in joining for that, it would be great to see you all there. I think registration is still open for that. So yeah, so it's just a one-day conference event. But yeah, so it'll be great to see people there if they can. And Jackie, did you want to share about the event for the Lewy Body Society?
Okay, thank you, Megan. On Thursday, the 17th of October, we've got a Scarf for Lewy, which is the 3rd year of this event. It's not a fundraiser, it's purely an awareness raising event. The first year we wrapped the Royal Albert Hall in London 6 times with a scarf. People knitted scarves, we sewed them together, and they came in from literally all over the world. With letters saying why people had knitted the scarves, who they were in memory of, what the colours meant. And we all know that knitting is good for your cognition as well. So it was really a good way of getting people involved and people that wanted to contribute to the event. Last year we did Waterfront Hall in Belfast, and this year we will be in Manchester, and we will be inside rather than outside, because Manchester in October at Central Hall, which is about a 5-minute walk from Piccadilly Station. We've got the Lord Lieutenant joining us. We've got our friend of the Society, Christopher Biggins, and some recorded messages from some celebrities who you need to come on the day to find out who they are, but there will be a press release later. Thank you.
Thank you, Jackie. I just want to say thank you everyone for joining for the webinar today, and a really big special thank you to Jackie as well for giving up your time and joining us today. So it's been great to hear from you. So but yeah, that's everything. So thank you again, and yeah, we'll see you all soon.
Thank you.
Thanks.
Thank
Bye,
you.
everyone.
Bye. Bye.
Thanks, Sandra.